Thank you for that warm welcome. So happy to be here as part of GAP, doing this community network discussion on MASLD MASH. There have been a lot of changes with the new nomenclature, the first FDA approved drug. So this is basically just kind of a brief overview and intro to all things MASLD MASH that hopefully anyone caring for patients with MASLD MASH will benefit from. So thank you so much for taking time to join us. We're going to jump into a case of MASLD basics. Again, I'm Lindsay Yoder. I am a PA. I work at Indiana University School of Medicine and Indiana University Health downtown at University Hospital in the Digestive and Liver Disorders in the heart of Indianapolis. There is a QR code here if you want to visit our community network to view more about the MASH disease state education materials. And so let's jump into it, right? Everybody previously knew this as NAFLD and NASH, or some people just used to call this fatty liver and not make a distinction as to the etiology. But our national organization, AASLD, realized something needed to change because NAFLD, or what was known as non-alcoholic fatty liver disease, had a couple of problems. One, that was a disease named for something that it's not, non-alcoholic, not what it is. And the word fat holds a negative connotation for a lot of people. So getting that word fatty or fat out of the name was, I think, what led to this new nomenclature. And then, a further recognition that steatotic liver disease, steatotic replacing fatty liver disease, really matters as to the etiology. If it is metabolic syndrome driven versus alcohol driven versus a combination of those things, and then an emphasis that it can be neither of those things. And it can be things like Wilson's disease or Hep C or medication side effect, and that the etiology is really important to distinguish. And so all of these things have led us to the new name of what we now know under that big umbrella of steatotic liver disease. So all the way over to the left, the new name for NAFLD is now MASLD, or metabolic dysfunction associated steatotic liver disease. When you have inflammation in the liver that's been created by MASLD, that's what we call MASH, metabolic dysfunction associated steatohepatitis. And then if you have someone who drinks more than 1 drink a day for women, more than 2 drinks per day for men, but not quite enough alcohol to meet the criteria of alcohol-associated liver disease, we have this new term that falls in the middle, which is MASLD. And so this is someone who has metabolic syndrome, someone who drinks a little bit more alcohol that's probably playing a role. And so it's a combination of both of those things. And that's what the MASLD is. So someone who has metabolic dysfunction, but they drink more than 4 alcoholic beverages per day, this is going to be your alcohol-associated liver disease. And patients with alcohol-associated liver disease who drink on average more than 4 alcoholic beverages per day can still have metabolic syndrome, but if they're drinking more than 4 drinks per day, we are going to call them and they're going to fall into that alcohol-associated liver disease because that's what's going to be most likely predominantly the driving force behind their steatosis, inflammation, fibrosis, which we'll get to. And then on the far left side here, we have to keep in mind sometimes there is cryptogenic steatotic liver disease. Someone doesn't meet any of these other criteria in terms of cardiometabolic risk factors. They don't drink a lot of alcohol. They don't have a specific steatotic liver disease etiology like Hep C, Wilson's disease, certain medications like amiodarone or methotrexate. And so we don't know. And so there is cryptogenic steatotic liver disease. And so, how do we get here, right? How do we follow this algorithm to come to the exact definition of what our patients have? So if there's hepatic steatosis identified on imaging or biopsy, usually this is an ultrasound or incidental finding on a CT or an MRI. The first question is, do they have any of these metabolic criteria? For adults, they only need to meet one out of these 5 things: BMI over 25, fasting glucose that's elevated, pre-diabetes or diabetes, hypertension or being on antihypertensive medication, elevated triglycerides or being on a lipid lowering agent, and then low HDL. So they only need one out of all of those things. And if you answer yes, that they have one of those things and they don't have any other causes of steatosis, then you can give them that definition of metabolic dysfunction associated steatotic liver disease, or MASLD. Again, if this is someone who has other causes of steatosis, then they might have a combination etiology. But if you go back to the beginning and someone has steatosis identified on imaging and they don't meet any of those metabolic criteria, and you'd say no, then you have to ask yourself, are there any other causes of steatosis, like alcohol, Wilson's disease, drug-induced liver injury? And if you don't have a reason, you can't find a single thing to pinpoint it on, then we have the cryptogenic steatotic liver disease. So MASLD replaces NAFLD, MASH replaces NASH, and these are pretty much identically interchangeable in terms of the old definition of fatty liver disease, NAFLD, NASH. And so all of the AASLD practice guidelines that exist on NAFLD, NASH can still be applied in the same way to MASLD and MASH. And again, reiterating that for that definition of MASLD, a patient needs to meet one of these 5 cardiometabolic risk factor criteria, and then you have to exclude other competing causes. So if someone has metabolic syndrome, but for women, they drink more than 1 drink per day, and for men, they drink more than 2 drinks per day, you can't call them MASLD. They may be MET-ALD, or again, if they drink more than 4 drinks per day, they're going to be alcohol-associated liver disease, despite also having cardiometabolic risk factors. So in the primary care setting, where there may not be a FibroScan readily available, how can you try to determine the next important question after you identify someone with steatotic liver disease? The reason we care, right, is do they have MASH? Do they have inflammation? And of those patients that have inflammation, do they have any fibrosis or scarring in the liver? Because ultimately, that's what's going to lead to clinical outcomes complicated by portal hypertension and liver cancer. So a very simple calculation that can be used by anyone, primary care, cardiology, endocrinology, is the FIB-4 calculator. This is available in many apps. And it basically has you enter age, ALT, AST, and platelets, and then it's going to give you a score. If that score is not above 1.3, then you're just going to repeat that FIB-4 every 1 to 2 years in someone who has diabetes or several metabolic risk factors, or you can do it a little bit less frequently, every 2 to 3 years, repeat that FIB-4 if they don't have type 2 diabetes and maybe only 1 metabolic risk factor. But if you plug that data into the FIB-4 calculator and that score of the FIB-4 is above 1.3, then you're going to need to do something in addition to try to really risk stratify, whether this is someone at low risk for advanced fibrosis or someone that's more at an intermediate or high risk of advanced fibrosis. So this is where you can order an ELF, enhanced liver fibrosis. This is a non-invasive test, or an NIT blood-based biomarker that can predict the degree of fibrosis. If you order the ELF and it's less than 7.7, that's low risk. If you order the ELF and it's above 9.8, they're more at that intermediate or high risk, and you're going to want to link them to care. If you happen to have access to order a FibroScan and you can get a vibration-controlled transient elastography liver stiffness measurement number, that's great. If you do that and their LSM is less than 8, they're low risk. If it's between 8.1 and 12, they're at an intermediate risk for advanced fibrosis, and above 12 on the FibroScan liver stiffness measurement is going to be concerning for a higher risk of a lot of fibrosis. And those patients that have an intermediate or high risk, these are the patients you're going to want to link to care with a hepatology provider so that more testing can be done to really identify if someone has MASH, and if they do, that advanced fibrosis risk. And then to say if their FIB4 from the get-go is greater than 2.67, that's high enough that you're going to want to link them to care. And this is where hepatology specialty care can come into play for those patients who have intermediate or high risk. We might consider a liver biopsy if the non-invasive tests that we have, the ELF, the FibroScan, other blood-based biomarkers, liver multi-scan, MRI technology, platelets, liver contour on imaging, if all of that non-invasive data is not congruent, that might lead us to a liver biopsy. So if we get a liver biopsy, their fibrosis staging is either going to be, no fibrosis or early F1 fibrosis. They could have Intermediate to advanced, stage 2 to stage 3 fibrosis. If you get someone with stage 4 nodular, histology, that's cirrhosis. So for us, if someone has no or early fibrosis, we're going to see them back in maybe 1 to 2 years, continue to follow them, reassess, and we are really looking for what happens over the next few years. And is this someone who's going to progress to developing more fibrosis or not? And what can we try to do to prevent it? Those patients who have MASH with intermediate to advanced bridging fibrosis, so fibrosis stage 2 to 3, we are definitely going to see them every 6 to 12 months. We're going to follow them closely. We're going to be a little bit more aggressive in how we treat them. And then happily, we have some pharmacotherapy options for this group. And then stage 4 cirrhosis, certainly they're going to get enrolled and enveloped into our cirrhosis care management plan, screening for varices, screening for hepatocellular carcinoma, and all of those other things we try to do to manage complications and clinical outcomes of portal hypertension. In some patients that we see, often we can avoid a liver biopsy, right? If we have enough non-invasive testing diagnostics that we can feel certain this is someone who has cirrhosis, then we don't always need a biopsy to confirm that. And it may be someone we can jump right to saying, we are certain you have cirrhosis, and take them down that pathway as well. So in terms of why is this important that we identify patients with MASLD, the patients with MASLD that have MASH, and the patients with MASH who have fibrosis and eventually advanced fibrosis and cirrhosis? This is a global epidemic. Overall, around 30% of the world population and around 30% of people here in North America have MASLD. A little bit higher in Latin America, a little bit lower in Western Europe, but overall, on average, around 30% of everyone in the world is affected by this. So 60 to 80 million Americans, to put that in a quantitative number of MASLD. Not all of them are going to have MASH, but those that do have MASH, again, we care because fibrosis is something that's going to affect them, and then over time, that progression to cirrhosis. So 1 to 2 million of that 60 to 80 million with MASLD over time are going to progress to having cirrhosis. Cirrhosis is then what puts them at risk for liver failure, the need for liver transplant, hepatocellular carcinoma or HCC, and eventually, if they're not a candidate for transplant and we can't reverse, the progression of fibrosis, death related to their cirrhosis and complications thereof. And so I'm sure you have potentially seen, if you are in GI or hepatology, right, that progression of the fibrosis can be variable. In general, we would probably say there's progression one stage every 3 to 7 years, but there are a small subset of patients where that progression is faster and they can hit cirrhosis within 10 years of identification and diagnosis. So the recognition, the diagnosis, and then the risk stratification of those who have advanced fibrosis is incredibly important, because the sooner we can intervene, the sooner we can treat, the more chance we have of halting the development of cirrhosis and all of those complications. So, I love visuals. This is great. This really gives you an idea, right? That someone starts out with a normal liver, and then there are all of these risk factors, metabolic syndrome features, alcohol use that put them at risk. Various genes, PNPLA3 is one that we are increasingly recognizing. Your genotype at that location can play a part in your risk for developing hepatic fibrosis and liver cancer. So you can progress then to having MASLD. Some things can be protective, like coffee, different genes that are protective, but the risk is then progressing to having early F1 fibrosis to moderate F2 to bridging advanced F3, and that can progress on to having cirrhosis. And then again, beyond just the risk of liver failure, that risk of liver cancer, right? So you start way back at MASLD and you have a patient who feels well, they feel normal, right? They don't have symptoms yet when they have MASLD. And really, even in early fibrosis, this is largely an asymptomatic disease. And so it can be really challenging to try to link in a patient's mind that we are treating this now to prevent the whole progression downstream of what could be if we aren't able to intervene and change the trajectory. So again, just a note that the rates of fibrosis progression vary greatly and depend on many different things, from environment, comorbid disease, genetic underlying predisposition that we can't change yet, and then cardiovascular disease and non-liver related cancer, still the most common cause of morbidity and mortality in patients with MASLD. And so that's why this multidisciplinary approach between GI, hepatology, cardiology, especially preventive cardiology, endocrinology. These are patients who need multidisciplinary care to take care of more than just their liver, but truly the risk factors that are going to cause the greatest morbidity and mortality until they start to experience signs or symptoms of liver failure remains, cardiometabolic morbidity and mortality. So we've got a patient here. This gentleman is a 55-year-old white man. His BMI is 35, and this is a typical referral you will get in GI or hepatology. He has a hepatocellular liver enzyme elevation, some right upper quadrant discomfort. He's gained some weight over the last 5 years. He's got normal ALK phos, normal Billy, but you see his ALT, AST transaminases are a little bit high, right? Normal for men, we would say, is less than 30. So these aren't even quite 2 times the upper limit of normal, but this is someone who has those cardiometabolic risk factors, right? He's obese, he's got prediabetes, he's got hypertension, does not have any known history in his family of liver disease. He rarely drinks alcohol and he works in IT. So he might be pretty sedentary, and he's on an antihypertensive for his hypertension. And on physical exam, he's got an enlarged waist circumference with central abdomen adiposity. So the first thing we need to think about with these elevated liver enzymes are making sure we rule out additional causes of that ALT, AST elevation. So we're going to need to screen him for different things like viral hepatitis, Wilson's disease, hereditary hemochromatosis. There are some other etiologies there that you can read. And then the other thing that's really important, again, thinking about those other causes of steatotic liver disease, is this is someone we need to make sure has no history of amiodarone, methotrexate use, tamoxifen for breast cancer. I still ask men if they have any history of breast cancer that I, didn't come upon in reviewing their records, and some of the antiretrovirals. So for this gentleman, lab evaluation consideration, again, you're going to rule out Hep B, Hep C. You're going to get a ferritin and a transferrin to screen for hereditary hemochromatosis. You're going to get an ANA and an ASMA to rule out autoimmune hepatitis, alpha-1 antitrypsin phenotype, because that can be a disease modifier, and a level to rule out a deficiency. You're going to get a CBC to make sure he doesn't have thrombocytopenia. Repeat the CMP, you can fractionate the bilirubin, you can look and make sure he has good renal function, INR to ensure that synthetic liver function is normal, and then the metabolic syndrome labs that you're going to want to get updated, lipid panel, A1C, TSH. And I have gotten in the habit of ordering a PEth on all of my patients with steatotic liver disease, just to confirm that what they tell me in their history is accurate. I would say I would actually not get an AMA for this patient because his ALK phos is normal. So I'm not screening him for cholestatic liver disease. There are some patients who, or some providers I know who will do kind of that full serologic evaluation, regardless of the pattern of liver enzyme elevation. But me personally, I wouldn't order an AMA for him since his ALK phos is normal. And then if he had not already come with some kind of imaging, most of my patients come with an ultrasound, usually showing steatotic liver disease, but that can be diagnosed on ultrasound. If he did not have any imaging of his liver, I would consider that, but definitely get a FibroScan. Lucky enough to have that in my hepatology clinic that I can order as point of care. And with that CAP score, I could diagnose steatotic liver disease that way also. So what you typically are going to see on an ultrasound report is increased hepatic echogenicity. Sometimes you'll see focal fatty sparing. In this gentleman, it showed that his liver contour was nice and smooth, no nodular liver or concern for cirrhosis. His spleen was not enlarged, no splenomegaly. And so the impression is that he has hepatic steatosis, no evidence of portal hypertension. So then the question, right, if we have diagnosed him with MASLD, what we care about is there a chance he has MASH? And if so, is there a chance he has advanced fibrosis, moderate to advanced fibrosis? So some things we could do, again, we can calculate a FIB4. I don't do that in my practice since I'm in hepatology and have a FibroScan. You can order an ELF. You can order a FibroScan to get that liver stiffness measurement. And again, if your non-invasive tests are discordant, there are still times where histology is, what ultimately tells you with more certainty the fibrosis staging. So for this guy, if we think back to our algorithm, right, he meets the diagnosis of hepatic steatosis that was identified by ultrasound. When we say, does he exhibit any of the criteria of metabolic risk factors, he has at least 3, his BMI that's elevated, his pre-diabetes, diabetes, his hypertension. So the answer is yes. And then this is not a gentleman who has medications associated with steatosis. We did a serologic workup ruling out any other chronic liver diseases, and he rarely drinks alcohol. So other causes of steatosis for him, the answer is no. So this is how we get to his diagnosis of MASLD. And again, beyond that, does he have MASH? Does he have fibrosis? Is it advanced fibrosis? These are the important things that we need to know. And if you are primary care, if you are endocrinology, if you are cardiology, if you are anyone else, community GI, and you don't have an answer to those questions, go ahead and refer your patients to us in hepatology and let us get through that algorithm to risk stratify them and find out and make sure we're not missing advanced fibrosis that could be treated with new pharmacotherapy, or certainly not missing cirrhosis and someone who we need to start screening for those clinical outcomes related to that. Thank you so much again for taking the time to go on this MASLD MASH basic review. I really appreciate it and hope to get the chance to interact with you and your patients one day.